Good morning to all of you, and thank you for joining this webinar. It's a pleasure for me to introduce this webinar organized by ESU and RCC working group, YAO RCC working group. The webinar will discuss about innovation in localized renal cancer, considering the role of biomarkers and molecular imaging, but also the role of stereotactic body radiation therapy. The idea of this webinar that was made by our YAO RCC group, so myself and all my colleagues that work on the scientific project of the YAO RCC group, is to explore what we think are the key innovations in the management of localized renal cancer. So we invited some experts discussing about biomarkers, molecular imaging, and SBRT, focusing on how these emerging tools can refine patient selection, but also improving treatment response assessment and enhance the disease characterization of RCC. The discussion will touch also the ongoing challenges in integrating these novel technologies in our daily clinical practice and evaluating the readiness of these approaches for a broader clinical implementation. So first of all, I want to introduce the moderators of this webinar. So we have with us Laura Marandino from UK, Riccardo Campi from Florence, and Giulio Francolini from Florence, that are a medical oncologist, a neurologist, and a radiation oncologist that are active members of our YAO RCC group. So please, Laura, if you can introduce the first speaker.
Sure. So the first speaker is Dr. Zed Tipu from the medical oncology team at the Royal Marsden Hospital in London. Zed recently completed his research degree at the Francis Crick Institute under the mentorship of Professor Samar Turajlic. And his talk is entitled Biomarkers in Localized RCC, Where Do We Stand? Please, Zed.
Thanks very much, Laura. It's a real privilege to be introduced by very much for the very kind introduction, and thanks to you all for joining this evening, and a good evening from London. So as Laura mentioned, kind of my research has been in the biomarker space in kidney cancer over the last couple of years, really both in the context of prognostic biomarkers, but also in terms of predicting therapy outcomes for patients with advanced or metastatic disease, and a real privilege to join you all this evening. So I think we can all say that we're at a point in the context of the management of kidney cancer where thankfully the treatment options are ever expanding. A lot of this has expanded from settings in the advanced disease through the advent of combination approaches, both PD-1 CTLA-4 inhibition and then also PD-1 VEGF inhibition. But more recently that this is now transposed for patients with localized disease. We now know clearly that there is a disease-free and overall survival benefit from the use of adjuvant pembrolizumab through the KEYNOTE-564 study, which now represents a standard of care for some patients with localized intermediate to high risk disease. But there are still lots of outstanding questions in this space. We know that 3 registration studies were negative, interrogating adjuvant anti-PD-L1 inhibition, perioperative PD-1 inhibition, or combined immune checkpoint inhibition in this space. And we'll wait the results from the Rampart study, which will be presented later this year at ESMO, looking at a combination of different PD-L1 CTLA-4 inhibition. But equally, if we look at the placebo arm of KEYNOTE-564, we know that adjuvant anti-PD-1 inhibition for this population represents overtreatment in about 50%. Those that represent surgically cured from intervention and in whom adjuvant treatment represents significant overtreatment with no additional efficacy benefit, but risks unnecessary toxicity. And the challenge at the moment is that the stratification tools that we use, stage, grade, are insufficient to identify those in whom don't benefit, or indeed those responder subgroups. And at present, the challenge in kidney cancer is the lack of implementable biomarkers that we can use to translate into clinic to optimize this risk stratification. But we know that there's been a wealth of work in terms of the biomarker space, largely in the advanced or metastatic setting. Lots of focus has been on tumor molecular features. This is aberrations in both DNA or RNA. And more recently, a lot of work has gone into spatial immune phenotyping, characterizing the tumor immune microenvironment, looking not just at T cells, but also their important reactions with a number of different myeloid subsets, as well as the emerging role of B cells, particularly in the context of tertiary lymphoid structures that we'll touch base on. And more recently, the challenges has been well explored relative to the use of circulating tumor DNA, the challenges in kidney cancer with low levels of tumor shedding, requiring deep levels of sequencing and lots of artifact, and this hasn't translated into kidney cancer, as opposed to a number of other GU malignancies where we've seen lots of emerging data. But more recently, the advent of KIM1, particularly in the context of prognostication for those with localized disease, but also in the context of monitoring responses longitudinally for those with advanced or metastatic disease. And we'll touch on some of these today over the next 10 minutes or so. So firstly, characterizing tumor genomics. So these are, for those maybe less familiar with this, mutations within the DNA within kidney cancer. And this is something that has been largely explored through broad-scale molecular profiling studies. We know what the molecular landscape of kidney cancer is. The next question is, can we use this as biomarkers to prognosticate patients with localized disease in terms of quantifying or establishing their risk of recurrence or relapse? And lots of work in this space. I think the first thing to point out is that we know relapse in kidney cancer or clear cell renal cell carcinoma, to be more specific, isn't a binary feature. It's not just progression or no progression. We know that the phenotypes of clinical progression are hugely variable, ranging from the 50% of patients that will never relapse from post-definitive nephrectomy to those that present with attenuated patterns of progression. These are prolonged periods of latency following definitive surgery, often measured in years prior to often oligometastatic relapse, whether that be isolated sites to the lungs or bones, who may well be better served by localized therapies such as surgery or radiotherapy, rather than the need for systemic drug treatment. And equally, those 25% of patients with the traditionally born to be bad tumors, those with very short relapse-free intervals from definitive nephrectomy, or those that either present with synchronous metastatic disease. And some of the work that we and others have done through the TROSEX Renal Consortium through broad-scale molecular profiling, interrogating the DNA, has characterized the molecular landscape which rationalize these diverse clinical phenotypes. We understand that those tumors with very limited risk of progression or metastatic progression are typically driven by isolated loss of VHL, a tumor suppressor gene on chromosome 3, whereas acquisition of a number of additional driver gene mutations on this same chromosome, so mutations in PBRM1 and SETD2 seen in up to 40 to 60% of clear cell renal cell carcinomas, drive this pattern of attenuated progression, these prolonged periods of latency prior to oligometastatic relapse. And then critically, in these born to be bad tumors, those with very short relapse-free intervals prior to metastatic progression, these are often characterized by mutations in BAP1, another tumor suppressor gene on chromosome 3, but critically are identified by loss of hallmark copy number alterations. This is loss of the short arm of chromosome 9 or the long arm of chromosome 14. And this is a population of patients who are characterized by high levels of chromosomal instability, lots of copy number changes within their chromosome, which we think is driving their aggressive disease, clinical phenotype, short relapse-free intervals, or indeed, this is a patient population characterized by presenting with synchronous or stage 4 disease at the outset. So we've had a look at this in a little bit more detail, and we've interrogated internal UK-based cohorts looking at whether we can optimize or integrate molecular features to optimize the risk of relapse. And again, when we looked at the clinical criteria for adjuvant therapy, this is stage 3 disease, stage 2, and grade 4 disease, in our patient populations, it's accurately identifying those with a risk of relapse to an AUC of only 0.523. The question is, could we then use molecular features to optimize that risk of stratification? And this was actually some of the work led by a group from Leeds through the KHKID consortium, who've looked at integrating these molecular features, the addition of a number of driver gene mutations above and beyond VHL. And what they see is that by the acquisition of one or more of these driver gene mutations above and beyond VHL, associating with worse DFS, worse recurrence-free survival, this is a higher risk of group. This is higher risk patients in terms of risk of relapse, and maybe a stratification tool to optimize patients or identify patients who would most likely benefit from adjuvant therapy. We then took this a step further with some of our internal cohorts and combined these features, so the presence of 2 or more driver gene mutations above and beyond VHL, integrating a number of other molecular features, things such as chromosomal complexity, that degree of the chromosome affected by aberrant copy number alterations, looking at these things called frameshift insertion or deletion mutations, short insertions or deletions into the tumor genome, and the presence or absence of coagulative necrosis to basically improve that risk of stratification, going from almost an AUC of 0.5, improving that to an AUC of 0.824. So presenting a potential tool of stratification to identify patients most likely who won't benefit from adjuvant therapy, those that we think where surgery in and of itself will suffice. But looking beyond DNA-based mutations, a lot has been made of looking at the bulk transcriptome. So these are looking and classifying tumors according to differential immune clusters to identify these tumors as either immune-driven, angiogenic, metabolic, stromal, off the basis of differential gene expression or upregulation of relevant pathways through interrogating their transcriptome. And a lot has been made of this in the context of advanced or metastatic disease. Many of you will be familiar on the call with the Emotion 151 study interrogating atezolizumab and bevacizumab for those patients with advanced or metastatic disease. And we know that post-hoc analysis of the bulk transcriptome identified 7 distinct clusters, which was able to identify which subgroups of patients would most benefit from combination approaches with a PD-L1 backbone versus those that are most likely to benefit from VEGF-targeted treatment alone. The challenge with these are that they struggle to cross-validate between studies. When applied from one study to another, they don't cross-validate. And this is the real challenge with using molecular or tumor intrinsic biomarkers, which often rely on single region archival tissue to predict response. And the inherent problem of this in kidney cancer is we know that there is inherent intratumoral heterogeneity. And what do I mean by that? There's inherent diversity, both at a genome and a transcriptome level. So where we are reliant on single region tissue samples for biomarker analysis, this underestimates this heterogeneity. So say, for example, your archival tissue represents this area. The molecular features that you pick out from that, whether that be genome or transcriptome, do not reflect the features represented in other parts of the tumor. So you're getting a false readout relative to the representation more broadly of these features. And these are why these really struggle consistently between cohorts to validate at scale. So really the premise of what we need to do for molecular or tumor-based features is identify novel methods that may overcome this. And some of the methodologies we're trying to pioneer through some of our prospective studies, but also others through the use of digital pathology, where we can profile the tumor at scale using diagnostic H&Es as kind of the cornerstone of pathology workflows, which represent the entirety of the tumor specimen, and identifying whether we can predict morphological features through underlying molecular aberrations. And lots of work going on in this space, but not yet ready for prime time. Moving on from molecular features, whether that be the genome or the transcriptome, lots of exciting work is going on in terms of the proteome, in terms of spatial immune profiling technologies, which have really emerged and expanded. So we know that clear cell renal cell carcinoma is immune infiltrated. It's characterized by a high number of infiltration of immune cells, which paradoxically in kidney cancer associates with worse survival outcomes. But actually looking beyond purely quantifying CD8 T cells, I think we're now increasingly understanding that their phenotype is important. We know that upregulation of this resident memory CD8 T cells is really important, but beyond looking at any single immune cell population in isolation, actually the real critical feature here is their interaction between immune cell mediators within the tumor immune microenvironment, whether that be with myeloid populations, which we know associate with increased risk of recurrence, particularly these immunosuppressive myeloid populations, but also increasingly the importance of B cell populations in the context of these tertiary lymphoid structures. And what do I mean by a tertiary lymphoid structure? Well, these are these ectopic lymphoid organs, which we know are present within certain kidney cancer populations as a real critical site for B cell maturation and differentiation into plasma cells, which then propagate out into the tumor bed. And some of the spatial profiling work that we've done at the Crook has really identified these as surrogate biomarkers for immunotherapy response. We profile in-depth tumor tissue after treatment with combined immune checkpoint inhibition, and we see this real enrichment for the presence of mature tertiary lymphoid structures present throughout the tumor, associating with real durable response in the context of advanced disease. And we think that these insights will translate in earlier stage disease relative to identifying patients that will benefit from adjuvant anti-PD-1 therapy. And maybe very briefly for the last point, we'll touch on the circulating biomarker piece. As I alluded to earlier, this has been a real challenging space for kidney cancer. ctDNA hasn't translated into an implementable biomarker for clear cell renal cell carcinoma. And we think that this is largely because of low levels of tumor shedding into the periphery, which will require really deep levels of sequencing, lots of artifacts, and isn't clinically translatable. But what we've really seen is the emergence of KIM1 as a potential really clinically implementable biomarker. For those maybe less familiar with KIM1, we know that this is a transmembrane glycoprotein initially quantified by our nephrology colleagues as a marker of acute kidney injury, but also associates with kidney cancer. And there's been lots of work led by groups largely at Dana-Farber, Vincent Hsu and colleagues, which have identified this as a robust biomarker, both in terms of prognosticating patients post-definitive nephrectomy, where high levels of KIM1 associate with worse disease-free survival and overall survival outcomes, but now also is a potential utility to stratify patients for adjuvant therapy. So we know from Checkmate 914, this was the adjuvant study of ipi/nivo versus nivolumab monotherapy versus placebo, that high levels of post-nephrectomy KIM1 associate with worse disease-free survival outcomes. And again, some on the call will be familiar with some of the data that Laurence Albiges from Gustave Roussy presented last year at ASCO, identifying the utility of KIM1 in Emotion 010. This was the adjuvant study of atezolizumab versus placebo. The study overall was negative, but what they found here in the intention to treat population was high levels of KIM1 in the entire population associated with significant worse survival outcomes post-nephrectomy, but actually that this was a phenotype that was rescued in part by the subgroup of patients who had KIM1 high disease and then went on to adjuvant anti-PD-L1 inhibition versus the placebo. And this is shown in the Kaplan-Meier group. So KIM1 high subgroup here, that the survival outcomes in this subgroup was better for those patients with adjuvant atezolizumab, a PD-L1 inhibitor, and that this wasn't seen in this better subgroup, overall better survival outcomes, but also no rescue from the use of adjuvant therapy in this subgroup. And not only have we identified that this one-off time point post-nephrectomy may be able to better prognosticate, but we also know that it may have value in terms of a longitudinal marker as a surrogate for minimal residual disease. And here we see from longitudinal samples in the Emotion 010 cohort that certainly at the time of disease recurrence, we are seeing an increase statistically in KIM1 levels. So a real value not only in terms of prognosticating at the outset, but potential value longitudinally in patients either undergoing surveillance post-nephrectomy or indeed for those patients who are having adjuvant anti-PD-1 therapy. Obviously, its translation into clinical practice will need prospective validation in patients who are having adjuvant pembrolizumab, as that which represents standard of care, and this is something which is still pending, but this will represent the next step in terms of implementation into the diagnostic paradigm. But as we've alluded to, really at present, there are no clinically implementable biomarkers, and I think part of this is the challenge of looking at these things in isolation. We've looked at tumor genetics, we've looked at the tumor immune microenvironment, and now increasingly in circulating biomarkers. The challenge, and I suppose the question is, if we integrate these features together, do we result in more sensitive or more reliable predictors for recurrence and for therapy outcome? And we think the answer in part is probably yes. And this is some of the work that we've just established in the UK in the latter part of last year called the Manifest Project. This is a 4-year project through the UK government, which is establishing a large-scale immunotherapy profiling platform to look at biomarkers of response and resistance. The QR code in the corner will take you to the website, and please feel free to reach out to any of us if you've got questions about the project and what we're doing. But this has been set up across 6 hospitals in the UK, as well as 14 academic institutions with good collaboration in terms of industry partners. And really the question we're trying to answer here is to identify implementable immunotherapy biomarkers, both in the context of adjuvant disease, perioperative disease, and also in the advanced setting. We're looking to profile 6,000 patients, of which a quarter of which will have kidney cancer over the next 4 years. And really the premise for Manifest is to move away from single biomarkers, so single assays or tests, to generate multimodal biomarker signatures, which we think will more reliably predict therapy outcome, response, resistance, and toxicity across tumor types. And you'll see here the 6 workflows that we will be profiling these 6,000 patients across our 6 hospital sites in the UK. And these are looking at some of these features that we've touched on already, these molecular profiling efforts, these circulating biomarker features, some things looking at the tumor immune microenvironment and others. But the real value of what we're trying to prioritize here is not looking at these things in isolation, but really trying to integrate this data at scale to really generate these robust biomarker signatures going forward to better prognosticate our patients, but also to predict response, resistance, and toxicity. This will be going on over the next 3.5 years, and hopefully there'll be useful insights that will derive from this work over that timeframe and beyond. So that's a real whistle-stop tour of kind of the biomarker landscape in the prognostic space. I've definitely gone over time, so I apologise for that. Would be delighted to take questions either now or later. Just to say a huge thank you to the teams, both at the Royal Marsden, where I'm based at the moment, the Francis Crick Institute in North London, and collaborators across the UK and beyond, and of course, patients and their families. Thank you very much.
Thank you, Zed. Really, congratulations on your talk and also on the work you are doing within the manifest, which is really about trying to translate all this knowledge in something that is ready for the clinic. And the question from the audience is about this. Or are there biomarkers panels available for clinical practice? And I already mentioned that there are no ready for clinical practice. And also, what will be your advice for urologists? How should urologists approach patients who request biomarker testing outside of clinical trials?
Yeah, thanks. So great questions, and thank you very much for them. So I think to the point one, we're a long way away from clinical implementation. So I think a lot of our work has been in retrospective registration studies, and what we really need is prospective integration to translate these into clinic. I think I'm going to slightly tangent away here because I think there's a really unique opportunity here. So we know that adjuvant immunotherapy has a space and a role. What we know from other tumor types is the emerging role of neoadjuvant immune checkpoint inhibition, and lots of people have reported this. Lovely work from Laura, Daniele, Ricardo, and colleagues in terms of a review published recently in this space. So we know that there's probably going to be a signal, and what these neoadjuvant studies do is they give us this real window of opportunity to characterize dynamic changes under treatment in terms of the molecular landscape, which may predict response or resistance. The other question is, what does pathological response mean in kidney cancer? We have absolutely no idea. I think there's really emerging role in melanoma with immune checkpoint inhibition. The path response is a really great surrogate outcome. So I think these neoadjuvant studies will present this great translation opportunity from understanding these biomarkers and then implementing it into clinic. To the second question, and this was kind of how we do biomarker studies outside of the context of clinical trials, it's really challenging. And I think the value here is if we can do, is through local biobanking efforts from individual hospitals. And I think Italy does it very well. The UK is some way behind in that space, in which we collect these longitudinal samples and then collaborate between centers and sites. So for example, for Manifest, what we're doing is we've got 5 or 6 hospital sites open, but what we're also trying to do is extend that beyond broadly within the UK, that we can access other sites and centers who have got these historical biobanks of sample. These are tissue, these are blood. All of these patients will have archival FFPE samples that we can then process and profile at scale. And I think the critical thing here is it's the scalability of all of this. If you do it in silo, in isolation, in small numbers, you'll never get the answer. It needs to be done in the hundreds.
Perfect. So I think we might need to switch to the next talk. Yes.
Thank you, Laura. Good evening to everybody, and thanks for the opportunity to be here with all of you today. It's my pleasure to introduce Dr. Carmen Mir, who doesn't need any introduction. She is a member of the ESO, a member of the EU Scientific Congress Office, past member of the Renal Cancer Working Group. So, Carmen, you are the perfect person to present this topic about molecular imaging in localized renal cancer. Please.
Thank you, Ricardo, for the introduction, and thanks for the invite from the YAO group. Happy to be a former member. So we are going to go from a very fancy talk. I would say it's very interesting to me, the biomarkers. I think it's going to change the way how we approach, but also molecular imaging. You asked me to talk about molecular imaging in localized RCC. Are we ready for prime time? These are my complex. And basically, I will briefly mention what molecular imaging means, and I will talk about this three tests that I think that are more relevant in the current era, and then what we should look forward to in this topic. The issue that we have, the controversies in when we have line as urologists and in indeterminate renal mass, is that we don't have any test that we can actually make sure that what we see is tumor. Renal mass biopsy is operator dependent and is only indicated by guidelines if it's going to change our clinical practice, if it's going to change what we are going to do. What happens is that 20 to 30% of the times that we do a biopsy, this is non-diagnostic. Patients, they don't like to do a test and then they get no answer. And what happens is that with small renal masses, when it's less than 4 centimeters, up to 20 to, if it's less than 4 centimeters, sorry, up to 40% of them, they have benign disease. So it's very controversial for urologists what we should do in this area. And so that's when molecular imaging comes in, because it not only looks at the structure and the tissue, but also what's molecularly happening in the tissue. So it's like a biological picture of what's happening. And it's a non-invasive method. It's not like a biopsy, which is for patients a little more pleasant. And why does it matter to find this? Because it can help us diagnose better and stage better, so we treat better. We plan our treatments better, our surgeries or our chemotherapies or our SBRTs or whatever we decide to do. And we can also help us monitor the responses. So we should increase the treatment. We should increase in terms of doublets, triplets, or whatever we're going to give, or we should not. Out of the three tests I wanted to talk about, one is PSMA. It's well known for the prostate cancer. We have talked about it a lot. You know very well what PSMA is. It's basically a transmembrane glycoprotein, and it's well expressed in prostate cancer cells, but it's also expressed in endothelial cells, especially in tissues that have a lot of neoangiogenesis, like kidney cancer. This is an example of a systematic review and meta-analysis that we have so far last year on all the little retrospective series that have looked into PSMA for kidney cancer. As you can see, it's not very good for primary diagnosis because it has a lot of background within the kidney. But as you can see on the red spot, it does work a little bit in terms of looking at the metastatic disease. These are the results of the meta-analysis. And also it has been used as a gallium and as PYL. It seems like PYL works a little bit better for kidney, especially because the median time is a little bit longer and the image seems to be a little bit more clear. But it's very little data that we have. The longest series that we have so far published on this topic on PSMA for oligometastatic kidney cancer is from Australia. They have a lot of experience on prostate, but they also use it for kidney. And what we see from their results on oligometastatic is that PSMA actually did change their management in 50% of the cases that they used it on. And it detected 25% more metastatic disease than conventional CTs. What we don't know if this changes in terms of management actually does provide an improvement in overall survival. We only know that it changes management, but we don't know if it actually does anything on the long-term outcomes. In terms of the other test that I wanted to talk about, is Stamivy. It's been around already for probably more than 10 years. I remember first publication probably 2015. And Stamivy is well established for myocardial and parathyroid imaging. It's something that we have available in our nuclear medicine departments. And what happens is that Stamivy accumulates in cells with high mitochondrial content and that have low multi-drug resistant PAM. Why this is important? Because clear cell is the opposite. It has a very high resistant PAM expression. So it basically works for patients that have mostly oncocytic tumors. So what I did is I look at the series that are out there because to me it's an interesting topic and I've basically tried my best to summarize them. We have 3 on the top that actually go for it and 2 below that go against it. What I see from reading all these retrospective series is that most of the time, as you can see, they talk about a lot of renal masses, but only focus on very few oncocytomas. The results are based on this. And most of the time, they express the issue of controversial results with chromophones and oncocytic and oncocytic papillary patients. But you also see in the series that reports actually from Fox Chase from the US, the Shopper. It shows that actually it was not as good as they expected, and 20% of the patients that actually had a cold mass, so there was no capture in the mitochondrials, they actually had an oncocytoma. So the test actually failed a little bit more than what had been reported previously. What are the issues with all these series on systemicity and the hot and cold masses and oncocytic masses? So probably what has happened over the last 10 years is that pathology definitions and oncocytic patterns are different. We know that with the new definition of the WHO classifications, the spectrum of low malignant potential for oncocytic tumors has changed. There is also a lack of standard protocols for all these tests. Everybody does a different protocol, and there is no quantitative report in most of them, so it's subjective to whoever is a reader. And they are all small number of patients, that I said. Most of them don't even have large numbers of pathology assessments, so it's very controversial. What I found interesting is a concept that they describe at Hopkins. They've been using the test since 2015, and they did a cost analysis of different options available for indeterminate renal masses. And they found that the most cost-effective ratio was for patients using systemicity plus renal mass biopsy. Since, as you can see on the right, is the option 3, it would leave less tumors untreated. But still, it's controversial because in our context, the cost effectiveness of US is not really applicable. The last test I wanted to talk about is a more fancy one, girentuximab. You may have heard about it. It was presented actually at EAU 23 a couple of years ago, and it was one of the game changers. You may have heard about it, but it does, girentuximab, it binds to CA9. CA9 is upregulated mostly in clear cell, that is the tumors that have mostly VHL loss. Girentuximab has the specific characteristic that is excreted through the liver, so it doesn't have any issues with excretion through the kidney, which is the plus. And the ZIRCON trial, in brief, basically presented its results as primary endpoints. As you can see, sensitivity was quite high, 85%, 87% of specificity, and what we look at also negative predictive value, 75%. What do these results mean? So there are several things that we have to look at in order to compare to prior tests and see if this is worth or not. One of them is the accuracy, if there is a radiation exposure, any adverse events, if there is any variability amongst readers, cost effectiveness on long-term surrogates of endpoints. I will just walk you through it. If we do the math on this trial, what we see is that all the patients that had positive PET actually had tumor, either clear cell or non-clear cell. But there was actually 28 patients that had clear cell, but they had a negative tumor. That means that negative predictive value is around 75%. So 25% of the times it would actually be wrong. What we can take home, though, is that if the patient had a positive test, we can make sure that the patient has something that actually needs either clear cell or non-clear cell, which is also already an improvement. If just make a quick comparison with what we have so far in PSMA for prostate cancer, just to compare the results so you can have a feeling of what's happening. And we have not embraced PSMA for primary diagnosis yet. This is the trial that was used, the primary. It was presented in 22, and what we see is a negative predictive value of 81. Remember that ours was 75%, and it was not embraced. So that's telling you why it cannot be embraced as a unique test. If we compare with contrast CT, that's what we have been using so far, the 3 phases, corticomedullonephrographic and excretory. What we see is that specificity, as you can see, is quite low, 62%. It was 85% for us in the ZIRCON, a negative predictive value around 81%, so a little bit higher. And if we put it in context, comparing the two results, we can see that the specificity, that's something we worry about in this test. We don't want to have false positive. Is a bit higher with zircon, it gets better, but negative predictive value is not as good. If we look at radiation exposure, it's hard to measure, to be honest. This is an approximate, but we know that radiation is very low, and that's why patients need to be scanned at least 5 days after infusion. But this is for you to have a feeling about what's going on in terms of radiation exposure. So if we look at all the items, we know that accuracy is equivocal, it has plus and minus. For me, the plus would be that it actually, if it's positive, is telling you that you have a tumor. Radiation exposure is somehow a little bit more, and no adverse events. It's acceptable inter-reader variability. We don't know about cost effectiveness, neither about long-term surrogate outcomes. These are two examples of my real patients, just to give you an application of real life. That I use Zarcon as an early access. It's available in each of the countries. And as you can see, what we see is a little bit of bowel background. And in this case, this was a lady. I've been following her for 3 years for a small renal mass, and you can see it's very positive on the right. And we could see also an adrenal adenoma that was also present at the beginning of the follow-up, so we knew it was not a problem. In this case, very positive, so probably she has a tumor, and we don't know how aggressive, obviously. In this case, this is another patient of mine. I did a partial nephrectomy on the other side, and it was an oncocytoma. And then I've been following him for also, I think, a year and a half. On the other side, nothing has changed. And what we see here is a lot of background as well, but no captation, no activity on the right renal mass, which most of the time we would require a biopsy to make sure. As I told you, if it's negative, we don't know for sure what's happening. But in this case, we had a biopsy on the other side because the patient had an oncocytoma on the left. So it kind of reassures that most probably he would have the same on this side. So zircon does give us some improvement in terms of identification, but definitely is not ready for prime time from my perspective. And what we look forward in the future would be like 2 different ways of replacing biopsy in order to identify what's happening. Then we should also find the optimal tracer for the localized disease. I think also is how do we integrate all these findings that we have in the surgical planning, like if more intensity, should we resect more, for example? And what is the cost effectiveness of all these approaches? We have seen an approach where you use systemically plus biopsy that seems to work. So probably we don't have to look at only one test in order to decide. And also, I think we should kind of think about re-stratifying, more thinking about not benign versus malignant. This is not happening anymore. There is some grace in between. And we should move probably towards something like low malignant potential, not only oncocytic, but also from going to low malignant potential to aggressive behavior and deciding in between what we should do. Thank you very much.
Thank you very much, Carme, for this very comprehensive overview of the state of the art in molecular imaging. You did really a good job summarizing all this literature. We have a question from the audience, from Professor Erdem from Selçuk. Is there any evidence or ongoing study in the literature on molecular-based theranostic approach using girentuximab in RCC? Maybe Selçuk is referring also to localized disease. That would be ideal.
Sure, I had 2 slides about that, but since it was not localized, I didn't add them, but I can now. So yeah, so the role of therapeutic girentuximab exists. This is the first trial that was published, very small one, phase 2 non-randomized, only 14 patients. And the issue with this small phase 2 was the myelotoxicity. A lot of patients got very sick, so there has to be an adjustment on the dose, it looks like. And what is going on is Starlight 2, which is actually very interesting as a concept. It uses lutetium girentuximab plus nivolumab, but obviously it has to be only in clear cell in patients so far that are refractory. So it's still going, it's working. They have to figure out what is the best dose and what is the perfect patient. But yeah, there are some things happening in that area.
Thank you, Carmen. I have a question for you from a more clinical practice-oriented point. I think we all know that in the localized disease setting, what we would like to achieve is a more individualized approach to patients with a localized renal mass suspected of renal cancer in terms of deciding whether to do surveillance or non-surgical management, for example, SBRT. We will discuss that. Do you think that for these endpoints, is there already one of these promising agents that can be used in practice, or do you think we should wait more robust research in order to change our practice while waiting for?
You mean in terms of using systemically in real
Yes,
life, or
yes.
you think? As I said, I don't think none of them is ready for prime time. If you ask me if I would send a patient for systemically, honestly not, because as I mentioned, the data is very, very poor. If you really read the papers and look at how many patients this is based on, it's extremely poor. And in terms of girentuximab, I use it because it's an early access for these two patients, and I thought it could be interesting, but I'm not sure it can give us the whole spectrum of answers that we are looking for yet.
No, I think thank you for your answer, because I think this is important for practicing clinicians and not to rush over these molecular test results nowadays, because still we are doing research on that and the data are not so robust to guide clinical practice. Thanks a lot.
Thank you.
Now it's my pleasure to introduce Professor Piet Oost, a leading radiation oncologist working at the Iridium Network in Ghent, Belgium, and chair of the ESTRO-GU focus group. He will now focus his talk on use of stereotactic body radiotherapy for primary renal cell carcinoma, an emerging treatment option in this field.
Thank you, Giulio. Thank you for introducing me, and thank you for having me on board for this. I'm happy to discuss primary SABR for renal cell. It is something which is mainly steered from Australia, so I'm very thankful for Shiva Shankar, who actually did most of the work on this, and amazing work, as you will see, because 3 of the main publications that I will be citing he is the first author. So he is truly the leading expert, and a lot of him we've learned over the past years. So how have we come to SABR now, which has not been on the radar for most people for RCC in the past 2 decades? So why are we talking and discussing it now? As for learning objectives, I think it's important to highlight what evidence do we have today. How do we select that ideal patient? What do we already know from follow-up, and what are the most important pitfalls to avoid? And there are some important things to realize, both as radoncs, but also urologists and medical oncologists, when we start following these patients. So maybe for some, we are coming indeed from a myth of radioresistance to modern ablation. We know that the classical radiotherapy, giving many fractions over many weeks, isn't ideal, but the introduction of what we call SABR, or stereotactic body radiotherapy, was already done in '95, but it took us quite a while to move that forward to RCC and being introduced already 2 decades ago, with these first reports coming from Scandinavia mainly, and then moving it to where we are now, to also trying to deliver it in solitary kidneys, trying to establish an international consortium with the IROC, and then now with the Fast Track 2 results. So we have been seeing a nice evolution, but it took us 2 decades, although the technology already has been there for quite a while. To gather that evidence took us quite some time. So where should we start? Well, I'm starting actually at the end, and that's the best evidence we have for now. That's a prospective Fast Track 2 study led from Melbourne. It's a multi-center phase 2 trial, 70 patients who were medically inoperable. They had 100% biopsy confirmed disease, and they had also serial growth at enrollment. And there were two options. Either the patient got a single fraction or 3 fractions of radiotherapy. I will discuss the doses a little bit later, but I wanted to focus on the results first. What they saw is that their local control rate was 100%, which is amazing after around 4 years of follow-up. Freedom from distant failure, 97%, highlighting, of course, the good patients that were selected, that these were not your bulky disease. These were mainly T1, T2s. Gas-specific survival, 100%. And the kidney function loss on average is around 15 milliliters per minute that was lost. And I will put that a bit in perspective later on as well. So I must admit, these results are pretty amazing. Getting a local control rate of 100% is indeed what we're aiming for. And that is something where we can maybe in the future think of, are we as good at surgery? But I will show you some caveats and some differences, but also showing you the uniqueness of this specific approach. When we look at the other data set we have now, it's coming from IROC. They did a 5-year update of their data, showing a 92% cancer-specific survival, distant failure rate, again, very low, and local failure rate as well, fairly low. It's not the 100%, but we are approaching 95%. And the kidney function loss, 15 mLs in the fast track, here it's 14 ml. So more or less the same. So this is quite a constant. You see some potential kidney function loss, but it's quite minimal. So what can we do to guide us? Well, we can look at the best practice guidelines, and these are steered by the ISRS, and Shankar Siva is the first author of this specific paper on RCC. What do they recommend from those? It's mainly taken from the fast track. You can either do a single fraction, so that's just one patient visit, for tumors that are around 4 centimeters max. If they're larger, it's better to do it what we call fractionated, so 3 sessions of a high dose per fraction. Follow-up protocols, I will come back to that later, pretty standard. Do what you normally do, but do your first post-treatment CT not too early. Biopsy recommendations, well, it is advised to do a biopsy pre-SABR, but don't do it post-SABR because it does not make any sense. And I will come back to that as well. And the response assessment, I will show you an example later that we have to be aware of what we call pseudo-progression that might mimic progression, but actually it is disease control. So who is a good candidate? Well, this more or less sums it up. Typically, we are dealing with T1, T2s inoperable patients, although an operable patient, of course, technically for us, it doesn't matter if the patient is operable or inoperable, but mostly we are seeing more advanced age patients with severe comorbidities, high surgical risks. Sometimes we have some patient preference, but mainly it is the more inoperable patients we are seeing. Tumor sizes, again, there, depending on what the size is, we decide how to irradiate, well, at least the number of fractions. We'll also look a bit at the tumor location. Is it peripheral or more centrally located? We also look at where are the organs at risk surrounding that specific RCC. For example, we often see bowel abutting the renal mass, and then it's also sometimes better to go for multifraction or even beyond the 3 fractions up to 5 fractions, for example. We always document comorbidity, kidney baseline EGFR. If it's too low, then it's better to discuss this upfront with the nephrology department, especially for these patients who have CKD 3 to 4 disease, solitary kidneys, because of course, the worse the kidney function is upfront, the higher the potential risk of the patient ending up in dialysis. So how do we do a good follow-up and surveillance? When we start at the renal function, the question is, what can we expect? So here you see on the left-hand side, a planning CT, where you see the kidney that's being irradiated in yellow, so the normal kidney. In the red is the area we want to give a high dose, and typically we give a bit of a higher dose and surrounding that, so some safety margin. There you see that green line, the 100% isodose. So that's the region that still gets high dose. And that 50% or orange line on the left-hand side on that planning CT is already our lower dose. So that's half of the dose we want to deliver. And on the right-hand side, you see a DMSA scan, and it was recently published again by the group of Shankar, Siva, that if you map both your plan to the DMSA scan, you can nicely delineate not only the tumor, but also the expected kidney function loss. So as you see from baseline up to 24 months, what you can see on the DMSA is that the kidney function is entirely lost in that high dose zone. Of course, mainly it contains tumor, so that's not really an issue. But if you look at it from a perspective of what is the function loss on a nephron in your nephrons, and you extrapolate it to dose, which is here the x-axis, you can see that everything is quite fine, except when you start exceeding the 100 gray zone, and that's biological doses. And you're giving, if you give a single fraction of 26 gray, you're going above that 100 gray. You can clearly see that the function of that of those normal kidney cells in the area receiving 100 gray or higher is completely lost. And it's a different story if you give lower doses. So for us, it's extremely important to spare as much of the normal kidney function and deliver a lower dose there. If we can do that, we can better save the normal function. So the loss in renal function is 2 to 4% per gray, and that's a kind of a plateau once you go over 100 gray, where the function is completely lost. So if we summarize that a bit, what on average is the kidney function loss? It's that 15 ml on average. That's 20 to 30% of the kidney function that can be lost after 1 to 2 years. It's not an acute phenomenon, which is important. It's a gradual decline. And the baseline risk is there very important. The larger the tumor is, more central located, or very poor function at start is a very important risk factor. But even then, the dialysis requirement in the patients that were followed for now is less than 5%. If you see a big drop in your eGFR of 30% or higher, do consult your nephrologist. So that is something we always recommend. Follow up with your lab, do it every 3 to 6 months from the start, and that should be more than enough to follow these patients. If you look at imaging, and that's our main modality, whether the patient is primary RCC or is metastatic, we will do serial CT scans, and that's our go-to modality. Maybe we'll be going to PET scanning, and some of these tools might be better suited for that, especially for discussing metastatic disease. But here on your top left, you see a patient with a baseline image of a renal cell. The red arrow nicely points that out, where on the right-hand side, you can see our radiotherapy plan, where there's a very, very conformal plan being delivered there, giving a very high dose. If you look at the scan 3 years later, there is still a tumor or a mass at least visible at 3 years, and there is still contrast enhancement, and that's 3 years later. There's no real growth, but still contrast enhancement. And when you look at 5 years, finally, the lesion has almost completely disappeared. And if you compare the baseline, especially the coronal baseline with the 5-year coronal slice, you can clearly see it's almost like a surgical resection where you see scarring tissue. So it's very important when we discuss follow-up scans with our patients. It will be normal that there will still be contrast enhancement. So typically what you will see is that, especially during the first 3 to 6 months, and that's why we recommend not to scan prior to 6 months, you will see enhancing inflammation around the area irradiated. You can also see necrosis forming centrally, which is also normal, quite normal. And up to 2 years, there might still be rim enhancement with necrosis. And 3 years post-treatment, you will see gradual involution. Sometimes it goes a bit faster, but this could be a typical presentation. And if you look at this specific one, and these are several of these patients in this paper that were mapped and looked at what does an unenhanced CT versus an enhanced CT and the different potential phases. If you look at the pre-treatment, this is the black line, enhancement of the primary tumor versus the post-treatment, you still see an enormous uptake of contrast. So contrast enhanced CT is not ideal to follow the lesion we irradiated. Of course, it's good for everything else, but not for the lesion we irradiated. And that's, I think, one of the key take-home messages here. So what do you need to know? There's a slow involution over years. It can take up to 3 years or more before you see clear tumor shrinkage. And the overall response just continues after that. Don't think of persistent enhancement as a failure. This is not the case. Central necrosis will be normal. And the RECIST criteria, if you would apply those to your SABR cases, you will see that most of your patients still are not complete responders. You will see some potential progressive disease, especially early on, according to RECIST, but these are not progressing. And even some of them will only get a partial response as per RECIST. Don't biopsy. There is no point in doing a post-SABR biopsy. You will see mixed signals and don't know what to do with it. And even in the ones, and these were nice studies that were done where you do biopsy and there's still vital tumor early on, it doesn't mean anything. There is no prognostic value because these lesions will disappear or at least shrink over time. So this still is not progression, even though there might be, according to the biopsy, some tumor cells left. So defining true failure is not easy, and that's the most difficult one here. So we need at least progressive sustained growth or 2 or more sequential scans beyond that 9 to 12 months. So what we do is we take our 6 months, don't look at the contrast, but take your 6 months dimension and consider that as the new baseline from which you measure your subsequent follow-up. And that's just considered as a new baseline. So how do we follow? Pretty easy. First scan at 6 months, don't do it earlier. Then every 6 months to a year, do your lab monitoring, of course, monitor your kidney function. Easy thing to do, monitor the severe drops if they would be there. It is rare, but still something to consider. Clinical assessments, of course, typical things to do, blood pressure, symptoms, are there any? So your normal assessments, nothing special there. So you can just put it in a flow chart like this. But mostly there are 2 things to do, labs and imaging, and clinically see your patient as the third part. So when should we worry? Again, don't be fooled by expected post-SABR findings. What is concerning? Progressive sustained growth on multiple scans, new nodules that appear at the tumor margins that were not present before. That might be a marginal failure. Of course, new nodes or metastasis outside the primary site, which makes sense. And when to consider new imaging, well, that is when you have concerning findings. They might have an added value there. And only consider a biopsy when you think it will change your management. So don't do that routinely. So typically what we do is, if it's suspicious post-SABR, is there that consecutive growth? No, just follow your patient. Yes, maybe do additional imaging, maybe do MRI with perfusion to consider, is this viable tumor, yes or no, and only biopsy if that will change your management. For example, if you want to go for surgery anyway, but most of our patients were inoperable from the start, so why would they all of a sudden become operable? So these are just things we will have to live with for now until we have better imaging. Toxicity, different things to look at. 3 main points. Gastrointestinal, as said, sometimes the bowel is very close. It's very rare to have grade 3 toxicity, but nevertheless, it might be possible. So if a patient has persistent pain, acute abdomens, hematemesis, melena, immediate referral. This is a surgical abdomen. Very, very rare, but nevertheless could happen. Urologically, look at hydronephrosis, ureteric strictures. Again, something to consider, especially if it's a central tumor. And of course, kidney function loss, hypertension are very, very important. Do mind, in the fast track 2, grade 3 events were around 10%, no grade 4 to 5. So most toxicity is very mild and very manageable. But if it does occur, severe events can still happen. So take-home messages for me: schedule your first CT scan to assess the primary at 6 months. Don't do it earlier. Do your workups every 6 months through year 3, then you can do it maybe yearly if you want. Confirm progression on more than one time point, please. Monitor the kidney function and don't routinely biopsy post-SABR. Thank you for your attention. Happy to take any questions if there are any. And of course, maybe as a final one, these are the references. And as you can see, first order, Shankar-Siva, Shankar-Siva, Shankar-Siva. If you want to know anything about RCC, he's the guy to go to. Thanks.
Thank you very much for your nice and clear presentation. So we got time for one question from the audience, and I see it on the chat. So an average loss of 15 milliliter minutes in renal function is not negligible for some audience. Do you think this decline could be reduced with MRI-guided adaptive SBRT using, for example, an MRI-guided LINAC?
Well, the thing is, if we see it, it's mostly in the bigger tumors where a bigger proportion of the normal function is already gone and there's not much left. Also more seen in the solitary kidneys, where again, if the remaining function isn't that great, you will see a bigger loss. There is a dose dependency. So if you can get your margins as tight as possible, then I would say yes, there is potentially some gain there, but still you will lose something. Because if you really want to cover your primary with sufficient dose, you will always take some margin. So within that margin, there will be normal nephrons and there will be a bit of loss. Again, the smaller the tumor and the lower your margins, the more kidney function you will spare. The bigger the tumors, even with MRI, you will already be losing part of the normal nephrons that are intertwined still with the tumor, for example. So yes, there might be some potential, but you will always have some loss remaining.
Thank you.
Okay, thank you all for joining this webinar today. A special thanks to our speakers and moderators for their excellent contributions. Today we explored how SBRT biomarkers and molecular imaging are advancing localized RCC management through a better diagnostics, an improved patient selection, and a more personalized treatment. These technologies seems to shape the future of RCC care, and exciting developments are attended in the next year. So we will see what will happen in the future. So thank you all for joining. And last quick information, don't miss our next webinar that will be organized on November 11th. Co-hosted by the RCC working group and DESU, that will be focused on the surgical challenges in advanced renal cancer. So thank you all and have a good night.
Thank you very much. Bye-bye.
Bye.